Congenital scoliosis. What is congenital scoliosis? It is the lateral curvature of spine caused by presence of vertebral anomalies that result in imbalance of longitudinal growth of spine. So, in a congenital scoliosis, there must be vertebral anomalies present. These cause one side of the spine to grow more than the other side, causing scoliosis. The side which grows more becomes the convex side, and the side which grows less becomes the concave side. It is found in around 1 in 1000 live births. The congenital anomalies usually develop during the first 6 weeks of intrauterine life. Girls are affected 3:2 ratio compared to the boys, and a familial incidence of around 1 to 5% has been noted. Classification of congenital scoliosis or vertebral anomalies. It can be classified into failure of formation, failure of segmentation, and a mixed type which has both the anomalies in the same patient. Failure of formation is further classified into partial failure of formation, which includes wedge and butterfly vertebra, or complete failure of formation, which includes the hemivertebra. Failure of segmentation is further classified into unilateral failure of segmentation, which is the unsegmented bar, and bilateral failure of segmentation, which is called block vertebra. To understand these failure of formation and segmentation, we have to understand the embryology of vertebra. The vertebra forms from the paraaxial mesoderm around the notochord. These condense to form 42 pairs of somites in a process known as somitogenesis. The somites further divide into a dorsal dermomyotome and a ventral sclerotome. The dorsal dermomyotome forms muscles and dermis of skin, and the ventral sclerotome forms the skeleton of the vertebral column. Now, sclerotome around both sides of the notochord form the vertebral body. How is it formed? The cranial and caudal part of the sclerotome form the vertebral body. So, this is the caudal part of a sclerotome, and this is the cranial part of the adjacent sclerotome. They form one vertebral body. So, if we include both the sides, each body is formed by 4 somites. Somites form sclerotome, and the sclerotome form this vertebral body. So, the vertebral body will have part from 2 adjacent sclerotomes. And then the mesenchymal cell in between the cranial and caudal part will contribute to the formation of the intervertebral disc. The nucleus pulposus is formed from the part of notochord, and annulus fibrosus is formed from the mesodermal cells between the cranial and caudal part of the sclerotome. This formation of the intervertebral disc is known as segmentation, as it divides the vertebral column into various segments. Now, the failure of formation will affect the formation of the vertebral body. So, in failure of formation, some part of the vertebral body will not be formed, whereas the failure of segmentation will affect this segmentation stage. So, the vertebral body will not be segmented into different segments. So, in a failure of segmentation, some part of the vertebral body will be fused to the adjacent vertebral body. This fusion can be partial or complete. So, let us see the failure of formation. Failure of formation can be partial or complete. In partial, both the pedicles are present, whereas in complete, only one pedicle is present or formed. So, partial failure of formation can be a wedge vertebra in which one side is completely formed and one side is partially formed, but both the pedicles are present. Or it can be a butterfly vertebra in which there is an anterior central defect of formation. In complete, we have hemivertebra in which only one pedicle is present or formed. The types of hemivertebra can be segmented, semi-segmented, incarcerated, or unsegmented. In a segmented hemivertebra, both the superior and inferior ends have normal growth potential. So this is known as a free hemivertebra. An intervertebral disc is present on both the sides of the hemivertebra. In a semi-segmented hemivertebra, only one end has normal growth potential and intervertebral disc is present only on one side. In an incarcerated hemivertebra, both ends have growth potentials and intervertebral discs, but the adjacent vertebra compensate for it. So, this has less chances of progression. This is also known as carved hemivertebra, as if the hemivertebra is carved inside the adjacent vertebral bodies. In unsegmented type, no growth potential on either end of the hemivertebra and no intervertebral disc on either side. Again, this has very low risk for progression. So, in a hemivertebra which will have a higher growth potential, this convex side will grow more compared to the concave side and the deformity will progress more. Let us see the failure of segmentation. In failure of segmentation, we saw that part or complete of the adjacent vertebra are fused with each other. So, it can be bilateral or complete failure of segmentation or unilateral or partial failure of segmentation. The example of bilateral is block vertebra, in which the entirety of the vertebral body is fused with the adjacent vertebra. This has hardly any risk of progression. In unilateral, the example is unilateral bar and only one side of the vertebra is fused with the adjacent vertebra. So the fused side grows less compared to the unfused side, leading to a progression of the deformity. This side will grow more and will become the convex side, and this side will grow less. So this will have a higher chances of progression. Coming to the natural history or progression of the deformities. The progression of deformity in a congenital scoliosis depends on the type of anomaly. So, sometimes you are asked which has the highest risk of progression. It is a mixed type in which one side is a fully segmented hemivertebra with a contralateral bar has the highest risk. This will be present in the convex side. This will be present in the concave side. Again, a segmented hemivertebra will have a high risk of progression. Wedge vertebra has only slight risk, and a block vertebra or incarcerated vertebra has almost no risk of progression. Progression also depends on the number of anomalies. A higher number of anomalies has a higher chance of progression. Location of anomalies also influence the natural history of scoliosis. The thoracolumbar region has the highest risk of progression, and the thoracic region has a relatively low risk of progression. The initial curve at presentation has an effect on the progression, with a higher initial curve having a higher chance of progression. The global growth potential of each side of the spine also influences the progression of deformity, with a higher growth potential remaining, leading to a higher progression of the deformity. Now coming to the associations of congenital scoliosis. Spinal cord anomalies are associated with around 20 to 40% of these cases. What are the common spinal cord anomalies associated? They are tethered cord syndrome, Chiari malformation, diastematomyelia or split cord malformation, syringomyelia, and intradural lipoma. Cardiac defects are associated with around 10% of the patients, and genitourinary defects are associated with around 25% of the cases. The common syndromic associations are Vater and Vectoral. Vater includes vertebral defect, anal atresia, tracheoesophageal fistula, renal and radial limb reduction. If we add cardiac defects and limb defects to Vater, it becomes Vectoral. Another association is Klippel-Feil syndrome, which has short neck, low posterior hairline, and fusion of the cervical vertebra. Some other commonly associated syndromes with congenital scoliosis are Charcot-Levin syndrome, Goldenhar syndrome, and Mayer-Rokitansky-Kuster-Hauser syndrome. So friends, this was a discussion on the classification, associations, and progression of congenital scoliosis. If you like these videos, please hit the like button and subscribe to the channel for further videos. Also, comment in the comment section regarding the topics you will like to be covered in the future videos. Thank you.